There we go. Hello and welcome. Today we are going to be talking about eye anatomy from the perspective of an iridologist. Now I'm going to ask you to do me a favor. If you're going to watch this, or if you do watch this on the replay, when you receive that link tomorrow, for those of you who are attending live, drop a comment. And if you're just watching it on the replay and you're not even here with me live today, drop a comment, like the video, share it, let me know you're there. The more comments and likes and shares, and the more people who join my Facebook group who follow me there, it just helps to increase the visibility of the videos I post. And so I really appreciate your help with that. If you take just a moment to do that. All right, we've got Maria from the Philippines. Hello, Maria. Woo. All right. Anyone between Western Canada and the Philippines? That'd be everybody else, right? So good to have you with us. All right. Now, when we talk about eye anatomy, it's not the first thing that most people say, "Ooh, I want to learn all about the iris anatomy so I can do iridology better." So many people don't even pay attention to this. And it's a little bit frustrating. They think that they just need to look at the surface of the eye and they don't need to understand anything else. And that's kind of like saying, oh, what's a good analogy here? I can fix your car. I don't need to understand anything about what goes on in the engine. Now, you wouldn't trust a mechanic who said that I've never had a day of training in my life. I know the engine is under the hood and I can fix your car. I've got a wrench, right? You wouldn't trust that person anywhere near your car unless your car had already completely died and that person was your last hope. And the same is true with iridology. Learning a few markings does not make you an iridologist, right? We really want to know as much as we can here. So even though eye anatomy is not sexy, it's what we're going to talk about today. Some of you are new to me, and so just want to take a moment to introduce myself, because there's a lot of people out there doing iridology, and so I just thought I would just share with you who I am. My name is Judith Cobb. I am an IPA level 3 certified iridologist and an IPA level 3 certified iridology instructor. Now you'll see little tiny badges at the top here and big badges at the bottom. And they just started issuing badges in 2022. I've been a certified iridologist since, oh my goodness, since the early 1990s, and I've been practicing since the early 1980s. There was no certification in iridology when I started, just saying, right? And so IPA, when we are affiliated with IPA, we have to do upgrade CEUs. We have to stay current. And so I've just completed my upgrades for the 2024-2026 timeframe. So I am up to date and ready to roll. I've been in the wellness industry for about 43 years now. And I am also a nutrition professional. I've got the training and the professional affiliations with 2 Canadian associations because I'm in Canada. And I'm also a master herbalist. So I have a professional membership with the Alberta Herbalist Association. With all of this having been said, I love teaching. It's in my blood. My father was a teacher. My grandmother was a teacher. My husband teaches things. My children teach things. Teaching is in our blood, and we absolutely love teaching. In addition to that, I love working with my clients one-on-one in my clinic. And so it's kind of that weird division of personality where I love that one-on-one intimacy in the clinical setting, but I also love the teaching of groups. I've taught workshops too. I teach online primarily now because that's just easier. But I've also taught to groups of 500, and it doesn't faze me. 1 or 500, yeah, there's no nerves. Just get up there and do it, right? Just love it. So today, as we talk about iridology, I'm going to be introducing you to dynamic iridology, which is based on constitutional iridology, but it's the constitutional curriculum from the International Iridology Practitioners Association, with the addition of a little bit of nutrition, a little bit of herbology, a little bit of emotional stuff. And really trying to help holistic professionals learn and use iridology at a professional level. Dynamic Iridology System is the only fully mentored online program to teach nutritionists, herbalists, naturopaths, RNs, chiropractors, NDs, LMTs, RMTs, PTs, whatever alphabet is behind your name, if you've got an anatomy and physiology course already completed, then you fit into the category of who qualifies to take this course. The purpose of teaching the course is to help you assess your clients more quickly at a deeper level, and to create a rapport more deeply and a lasting rapport with your clients, so that you don't have to spend time outside of appointments creating assessments or creating reports or writing protocols for your clients. And so that the programs you create, your clients will be able to use, stick with, and be successful with. And as you do that, clients will want repeat appointments, and they will want to keep coming back. My clients typically come in for 4 or 5 appointments, then they're feeling great. They disappear for 4 or 5 years. They start to fall apart again because they've forgotten what we've taught them, or they're just getting older and things shift. And then they come back in, they do 4 or 5 more appointments. So I do almost no advertising, but I can legitimately say I do almost no advertising for my clinic. It's all word of mouth, and it's all clients coming back, which is really great. Long-term retention. I've got clients who've been with me for 43 years, like from the very beginning, which is very cool. So the goal of dynamic iridology is to teach you constitutional iridology and how to use it confidently, so that you can easily integrate what you already know about nutrition and herbology, if you've got those trainings under your belt, to confidently create doable programs in your paid client sessions. All right. So, and just a reminder that as we talk today, even I'll be touching on various things, and this is a really high level overview, a very introductory level we're doing today. But it's a sampling of the kinds of things you can expect, only much, much deeper when we get into the course. So the first thing we need to know about eye anatomy is how to tell a left eye from a right eye. Now that might seem pretty basic. If your client is sitting in front of you, you can tell if it's a left eye or a right eye, right? It's not a big deal. Left eye, right eye. And remember that if they're sitting across from you, their left and their right are opposite to yours, right? Now, sometimes you'll have photos like the ones you see on the screen, and you may not have any facial features from which to decide, oh, is this a right or a left? So the one thing we use is the fact that the pupil is not in the center of the iris. So when you look at the pupil in both of these photos, you will see that it is off center. There's a narrow side to the iris and a wide side to the iris. The narrow side names the eye. So if the narrow side is to the right of the pupil, it's a right eye. If the narrow side is to the left of the pupil, it's a left eye. So, when you're a trained iridologist, you sometimes work virtually. You've got clients from all over the world. They're taking photos and sending them to you for you to work with in your online appointments with them. And they don't label their photos, right? And they sometimes they've got the camera turned backwards. And so things can get pretty funny, but you can do a good job of determining left and right by looking for where is the narrow side of the iris. Now that is something that no one taught me until I'd been practicing for about 30 years, because we weren't working virtually back then. And I knew what order I took photos in. So I knew in my own image files, I knew which ones were lefts and which ones were right. But this is important once we start working virtually. So when we look at an eyeball, if you're going to med school, for instance, they're going to focus on the cornea. They might do a bit with the sclera. They'll do the lens. They'll tell you where the iris is, but they'll talk about it strictly as a muscle. They'll look at the posterior chamber. They'll look at the optic nerve. They'll look at the retina. So much of that is really not terribly important for iridology. Okay, we are concerned in iridology a little bit about the sclera, and if we're doing sclerology, we do some with the cornea, and we do a lot with the iris. We don't do anything with the lens, right? We don't do anything with the posterior chamber or with the retina or with the optic nerve. And so we want to focus on the iris, really, and that's where we're focusing today. So I want us to look at this cross section, and I'm just going to flip this No, actually, I'm going to teach about a few things before we get there. Just hang on. Okay, so yeah, some important things. The eyeball is the largest nerve receptor in the body, right? It is entirely a nerve ending nerve receptor. And the actual nerve that comes out of it is the optic nerve. Now, I know we've actually got an optometrist with us in the group today. She's just joined us. And so if I say anything incorrectly, please correct me, Pavlina. I'm serious. I take correction very well. The eyeball has two fluid-filled chambers, the anterior chamber and the posterior chamber, and they are separated by the lens and the iris. And again, the iris is, from our perspective, has a lot of muscle tissue in it. The pupil is an aperture. It's like a camera aperture. It's an opening in the iris. And so when you think about it, the pupil is actually a hole. All right, so when we flip that image on its side, here's the iris again. And now we're going to take this and we are going to look at a cutaway cross section of it. Now this can trip a lot of students up. So I want you to notice the pupil is here. The front of the iris that faces the world is here. We can't see the back of the iris. It's tucked underneath. And then the sclera is coming on this side. Okay, so here's the pupil. Here's the front facing edge of the iris. This is the back side of the iris that we cannot see because it was tucked under. And we're going to see, of course, the iris ends and then the sclera is over here. Does this image make sense the way I've explained it? Does it make sense what we're looking at? If it makes sense, give me a makes sense in the comments box. Chana says yes. Chana's seen this diagram many times. She's in the course right now. Liz is saying yes, yes, and Michelle says yes. Chana says makes sense. Fantastic, fantastic. Is there anyone, and this is the time to tell me, is this tangled up in your brain for anybody? Is there anyone who's going, I don't get it? If it's not making sense, give me an I don't get it in the chat box, because this is crucial that you understand this. Shanna will attest to the fact that in class, I'm constantly saying, does that make sense? Does that make sense? Does that make sense? Because if it doesn't make sense, nothing else will. And Shanna's laughing, going, yes, yes, I'm almost annoying with it, but it's critical. It's absolutely critical that you've got this foundation. All right, well, we're going to press ahead then, since everybody is suggesting that they've got this. First thing we want to look at is the anterior border layer. That is the very, very topmost layer. It's the layer that is to the front of the eye when you're looking at a person, and it's what you actually see. So the cornea is sitting up here. And then there's the anterior chamber, and then we hit the iris with the anterior border layer. And so this is the layer that holds the pigment. Now, in a blue eye, which we would call a lymphatic iris, there's very little pigment. In a brown eye, there is a lot of pigment. And so really the difference between a blue eye and a brown eye is two things. Number one, the density of the pigment, how much pigment is there, and the types of pigments, because there's a couple of different colors of pigment that can settle into the iris. And so again, the lymphatic iris has very sparse pigment, while the hematogenic or dark brown eye has very dense pigment. Then we have the bulk of the iris. This is known as collectively as the stroma. And this is made up of individual fibers. And I'm going to put that in air quotes because they're not really fibers that radiate towards the nearest edge. So if the nearest edge is the inner edge, then the fibers all originate and radiate back to that edge. If the edge is here, then we've got fibers that come in and come back out again. And so with this, we also have in here blood vessels and nerves and the muscles. And so this is a trabecular mesh. There's a little bit of a weave and a almost a netting to it, for lack of a better word, kind of sponge-like. And we just need to know that in that sponge-like structure, we've got all of these other organs and organelles and tissues that are very important. Then we have the posterior. Where's my mouse? My mouse has disappeared. There we go. The posterior membrane, which is also known as the dilator muscle. And so with this is the muscle that pulls the pupil open. Okay, this is the dilator muscle, posterior membrane. This is the muscle that pulls the pupil open. We have the sphincter muscle. This is the muscle that closes the pupil. And we need to know these. They play very important roles in an iris assessment. We also have this posterior epithelium. This is exactly 2 layers thick, 2 cell layers thick, and very, very dark brown or black cells. They wrap around the inner edge of the iris, extremely light sensitive. And it's these cells being acted on by light or not being acted on by light, as the case may be, that ultimately sends the message to the brain, sends the message back to the eye, that tells the sphincter muscle whether it should be constricting, or tells the dilator muscle whether it should be constricting or not. When we see separations in the iris fibers that go very, very deep, and we see black in that little gap in the iris, it has been suggested that we are actually possibly seeing the posterior epithelium. When we look at an eye, there are layers. Like we said, this isn't really in your eye like 1/2 inch thick or 3/4 of an inch thick. It's millimeters thick. It's very, very thin. But there are layers in the eye. So when we have a fiber that's doing this and is separated, what you're seeing in this gap is fibers that are down a layer, at least a layer. The darker the color, the darker the shading in that gap, the deeper we're looking. The more layers the fibers are separated for, so that we can look down in, like looking to a crevice if you've ever, or a crevasse, if you've ever been on an ice field on a glacier and there was a crack and you looked down to see how quickly it gets dark, or if you've been rock climbing and you looked down into a crack in the rocks and saw how quickly it got dark. Remember, we still have the cornea on top of all of this. And so you'll see that with this, it looks like some fibers are sitting very high, sitting literally above the surface of the eye. So if this is the surface of the eye, some of these fibers are sitting raised like this. And it's not that they've moved, it's that they've always been there. And some fibers are separated so that we are looking down between them. So we've got raised fibers, genetically raised fibers, been this way all along. We've got separated fibers where we can look down layers, and we can look even down deeper into the iris. So as we look at these muscles, this is the dilator muscle and this is the sphincter muscle. So the dilator muscle anchors into the sclera. Okay, it anchors into the sclera. And what that means is that when the dilator muscle contracts, the only thing that can move is this inner edge. So as it contracts, this dilator muscle telescopes in on itself. The other edge of this is anchored to the outer edge of the sphincter muscle. So when this dilator muscle contracts, the sphincter muscle gets pulled apart, gets pulled open. So when the dilator muscle contracts, it opens the pupil. Conversely, when the sphincter muscle contracts, again, because it is anchored into the dilator muscle, when the sphincter muscle contracts, it pulls on this inner edge of the dilator muscle and stretches it out. And that is what has to happen with those two muscles in order for the pupil to shrink down. We know that the iris has been estimated to contain 28,000 nerve endings. We don't know what all of them do. Some of them seem to end blindly in the stroma of the iris. That, you know, we're constantly making discoveries about the body to understand more and more about what's there. So this is, when you look at this image, you can see that there is an edge right here. Can you see this edge where we go from one hue to another hue? There's a very slight color variation and a slight density variation. Can you see that? If you can see that, give me edge in the comments box. Edge. Channa has lightning fingers. She's so fast. Everybody else see that? Liz can see it. Excellent. Anyone else? This thing that we're seeing right here, this is the sphincter muscle. That edge is the edge of the sphincter muscle. Okay. When we look at circulation in the iris, because this is really important, let's come back here. We're looking at these, essentially. We often call these fibers, which is a serious misnomer because they are not fibers. They are actually capillaries. And as with all circulation, there is an arterial flow and a venous flow. The difference about these capillaries is they are coated with collagen. And that's what makes them usually appear white. And so the arterial flow is always from the edge towards the collarette, towards this ring that is coming around here. Oops, there we go. And then the venous flow is always back to the edge. Now, they aren't quite hairpin like this. This is just a schematic. Inside that ring, it starts at the inner edge. The circulation starts at the inner edge, goes to the ring, and then the arterial flow goes towards the ring. The venous flow comes back to the edge. So we often refer to these fibers in iridology as trabeculae. Okay, and so these are collagen-coated capillaries, and again, they give us tons of information. Now, one of the things we need to remember with constitutional iridology is we are studying patterns of fiber structure, we're studying the base color, and we're studying surface pigments to assess inherited predispositions. A couple of things about that. Markings we see in the eye, unless there was an injury, are never the result of something the client has done. We never do an analysis without background information. I call that crystal ball iridology. That lowers iridology to the level of a party game. And we don't do that. So we are always wanting a conversation. We're always wanting to find out. We do want to find out some about the client's personal and family history. And some people say, well, that's cheating because then they're telling me what's wrong. No, they're telling me what their symptoms are. They're telling me what their family's symptoms are. And when I look at their eyes, I can then gain an understanding of why they have those symptoms. And so it's really important for us to have a conversation with our clients, because every marking in an eye is not critical in every assessment. It's extremely overwhelming to do an assessment where you're telling the client about every marking. Maybe you're writing a report for them and you're telling them every marking you see in their eye and in the sclera. And by the time you're done, well, there's no hope, right? They're overwhelmed. They don't know where to begin. You can give them a list of recommendations, but they don't know where to begin. And so when we do constitutional iridology in the dynamic style, we are always considering, what are the client's goals? When we look at their eyes, what does the eye tell us about what the client is wanting help with? And then from there, what further questions do we need to ask to get better information? So in this is a client of mine. She's in her mid-30s. She's had fertility issues. She was diagnosed with PCOS, which I guessed from just simply how long her menstrual cycles were and just her basic blood work, like her hemoglobin A1C. It was pretty obvious. She'd been trying to get pregnant for a couple of years. She'd conceived once and had a miscarriage. And of course, with PCOS, miscarriages happen at a much higher incidence. So as we look at her eyes, look for the layers. to see how dark some of these gaps are, which means that we're looking deeper into the eye, which means a reduced integrity in that reaction field. And so, this eye, again, because of many things that we see in here, for example, the way the collarette is sitting and some shadows in here and the texture of the collarette gives us information about her. But there's also things in her eyes that suggest that she might have the MTHFR defect, which is where the liver cannot properly methylate folic acid and B12 or cobalamin. That's very, very common in PCOS, and women who don't methylate well often have reduced fertility, right? So when I saw particular markings in her eyes that suggested that, I knew we needed to work that direction. I also could see from her eyes, based on specific markings and where they're sitting and the color of her eyes and various things like that, that her liver was probably very inefficient and needed a little bit of ongoing love from a lifestyle perspective. We also can see contraction furrows here. So we've got these wrinkles coming around the edges, and where they end and where we see other markings happening, it suggests again that there might be an increased compromise in her fertility. And so it's a matter of putting the markings together. I call it connecting the dots, because a marking can mean different things depending on where it's sitting and with other markings that we see. Now, we also notice that she's got a little bit of cloudiness here, which is actually in the cornea. And that suggests a personal history of liver enzyme insufficiencies. And so that makes me wonder, what is her carbohydrate metabolism like? And so knowing that she was PCOS and very likely type 2 diabetic, I asked about carb cravings and she said yes. And she had started working on cleaning that up and eating fewer carbs. A bit of a challenge. She's Asian. And of course, their diet is largely white rice and a lot of sugary sauces. And so we had a lot of work to do there. In the end, we were able to get her balanced, and she did conceive, which was really exciting for her. So when we're doing this, even, just looking at this little overview of structure and understanding the different layers to the iris and how they sit in the iris, that gives us the foundation to understand the individual markings, and then to link markings together to build out an understanding of the person, of their health, of why they have the symptoms they have. And as we understand that, hopefully you've got the modalities, whether it's nutrition or herbology or whatever you do, homeopathy, and hopefully that gives you what you need to do to be able to create a protocol for the client. All right, so if you want to learn more iridology, if you've got that anatomy and physiology under your belt, just going to throw this in real quick, that the next go round of the next cohort of dynamic iridology starts on April 11th, and we are doing enrollment for it now. You do need to know there are only 10 seats available per class. I am very strict about that. I know there are teachers who take 20, 30, 40 people in their course. They take hobbyists, they take everybody. I take professionals. And so that's why we limit it to 10, because I'm not teaching people who are just interested in this, who want to do this as a weekend hobby. I'm teaching people who want this professionally. And so with this, again, if you've already got your anatomy and physiology, I'm going to tell you in a minute how we can have a conversation to go over this. And here it is. If you've got that anatomy and physiology and you want to go deeper, I'm going to put this in the chat box. We need to have a little conversation over Zoom to make sure that this course is a right fit for you. Now, how do you know if it's a right fit for you? If you've got the A and P, and preferably you have nutrition or herbology under your belt as well, because that makes it so much easier to create your protocols. Homeopaths can do this as well. That works well for them. Aromatherapists can do this quite well. I've got a physical therapist who's using it very nicely in her practice. then that makes you a really great candidate. I've had students who have been certified by other instructors, but who weren't comfortable with what they were doing. They lacked confidence. They hadn't been taught how to use it. They've been taught the nuts and bolts, but not the practical application. So if you fall into that category, then this could be a really good fit for you as well, as long as you've got that A and P under your belt. And so again, there's a link in the chat box for you to take a moment to schedule a time to talk with me. It's not a high pressure sales call. It's really an assessing fit conversation. Think of it as a university campus tour. You're going to decide if this is the right school for you. So again, this is the only fully mentored program. Don't just teach you the program, teach you the stuff, but then mentor you for the long term. This is one of my students. We've got 3 slides from her before she took the course. And her name is Joyce Lee. She's a certified nutritionist and a clinical aromatherapist. Before she said, I'm so excited to have this opportunity to learn new and updated iridology under Judith's expertise and her many years of experience as a clinical aromatherapist, herbalist, and nutritional consultant. I decided to take an iridology course through the Institute. I thought it would be an excellent service to add to my practice. Unfortunately, I quickly realized that I wasn't going to get the knowledge, confidence, and results I wanted, so decided to drop it altogether. After finding you, Judith, I'm really looking forward to getting started. After just 3 weeks, she said, I'm learning so much from this course. So far, it has been a real eye-opener, no pun intended. I had no idea how little I actually knew about iridology. No wonder it was never working for me. There are many pieces to each individual's personal puzzle. The challenge is putting it all together and remembering all the little details. I love what I'm learning and appreciate your thorough teaching technique. After she finished the course and had graduated, she said, Judith is a wonderful instructor. She presents the material in this course in a concise, organized way. Every aspect of this iridology course is covered in detail. She clearly answers every question, no matter how trivial the student may think it is. Judith structures the classes in a way that makes them incredibly interesting. Clarification is clearly established through her instruction, discussion, and student participation. Upon completion of Judith's course, I feel very confident in my abilities and excited to offer iridology services to my clients. This course is an incredible value, highly recommended. So a little bit about the course itself. It is delivered via 2.25 to 2.5 hour long live webinar classes. So very interactive. You and the other students in your cohort, lots of interaction. Every class is recorded for playback on demand. So if you have to miss a class, no big deal. You can make it up by watching the recording. Live group mentoring twice each month. We have office hours twice each month where anybody who is in the course now or has graduated or who has certified any of my students are welcome to come to the office hours to ask questions, to share insights, to present cases, to practice doing a case presentation. A beautiful time for my students to actually really refine their skills. We talk about business, the business of iridology. We talk about camera equipment. We talk about insurance. We talk about all kinds of things in our office hours, things that there's maybe not enough time for in the class time. We have a student and alumni MeWe group. So our social media platform is MeWe. It's a private group for my students and my alumni. Again, it's our community to share information, to ask questions, and to support one another. 225-page digital textbook is included as my gift to you. It's downloadable and it has the most up-to-date IPA curriculum materials in it. 45 pages of digital downloadable cheat sheets. This is your study notes or your quick reference guide for when you are with a client. And there's a lot to learn, and you might remember the marking, you might remember kind of what it means, but you might not remember what kinds of questions to ask or what kinds of recommendations you might want to consider making. That's all in the cheat sheets as well. I include IPA certification for mentoring. Most teachers charge extra for this. I include it for up to 10 months after your final class date. Most of my students certify within 4 to 5 months after their final class date. This includes the requisite number of case studies that need to be done that I need to mark, that I then need to speak with you about. And it also includes preparing you for the IPA case study, which I also mark, and you and I will meet to talk about. It also includes mentoring for the IPA final exam, which is 240 multiple choice questions with a 4-hour time limit. And so my goal is to have all of my students pass that exam with flying colors on their first attempt. So with all of this, it's important for you to then recognize your learning style. Which of these things do you think will be most supportive for you? How do you learn best? So when you're looking for an iridology course, you always want to consider, how do you learn best? I think we've covered just about every possible way of learning in the way this course is set up. So again, the next course starts on April 11th. And early registration is open. So if you want to make sure you get one of those 10 spots, I encourage you to use that link, tinyurl.com/dynamic-iridology. And there you have it, a very high level introductory overview into the anatomy of the iris. In the course, we certainly go much deeper than that. But that gives you just a taste of what iris anatomy is all about. So just before we wrap up, any closing questions? Terry says, thank you, love it. So good to have you with us today, Terry. Any other closing questions or comments? If not, we're done a little early today, and that's just fine. So I'm not seeing anything come in. Again, if you are considering enrolling in an iridology course, I would love to speak with you. It's not a high pressure sales call. It simply is an opportunity for us to assess, is this course the right fit for you at this point in time? I look forward to speaking with you soon. Take good care, and we'll talk to you soon. Bye for now.